Hello, welcome to our series, Understanding Migraine, a series of short videos for healthcare professionals. We'd like to thank the HSC National Lottery offices in CHO Area 5, Waterford, for the grant for this event. In our first episode, we hear from Dr. Mary Kearney, tutor with the ICGP and GP with extended role in headache, who will look at emergency treatment of migraine in general practice. If you would like any more information on this video or on our services, please email info@migraine.ie.
The first treatment of headache in general practice. All too often, this is a common enough role for every GP. And of course, when you're presented with a really bad headache, it's often difficult to know what to do. The talk will take the format of what to do with the bad headache, what are the life-threatening emergencies, how to make a diagnosis, and the importance of taking the history of medication overuse. So you need to get the diagnosis right before you can start treating, and you need to look for the cause of this emergency headache. So the first thing is, does the person with the headache need to go to hospital? And then you must consider the red flags associated with headache. These are quite well known and were published in the early 1990s. They have been looked at since that time, but really they're much the same. The systemic symptoms, and of course here we often think of meningitis, the fever, the myalgias. Neurological signs and symptoms are always concerning, and people are often concerned. And there's sometimes a huge overlap between serious signs and symptoms of the people losing the loss of a limb, the use of a limb, maybe with migraine, and also the loss of maybe use of a limb with stroke. If you've a very sudden onset headache, this could often need a particular emergency. An older person, and then if your headaches have been, relatively minor and suddenly they make a big change, it's important to consider it. So we've spoken already about the thunderclap headache that comes on and the meningitis. So you're there in the emergency situation, you'll have a look at the person, check their eyes, see have they red eyes, because sometimes with the headache and the red eye, they can have glaucoma. Check the temporal arteries, which we're all aware of. Consider doing a fundoscopy, because if you've raised intracranial pressure, it is important to refer reasonably soon. The urgent headaches rather than emergency headaches are those with the papilledema, and a systemic illness, or the elderly person with a new headache, and if they happen to have a cognitive decline. So you've excluded the life-threatening emergencies. So which are most often secondary in nature. So you come on to the primary headaches. So is the headache on 15 days or more per month? And headaches on less than 15 days per month are usually not considered chronic. So at that stage, it's back to the history taking. And I'd like to just say that the Migraine Association of Ireland have this very nice diagram, which they produced a number of years ago, and we reproduced it in a recent document on migraine with the ICGP. And it gives you a very good idea of the different headaches, the features of them. And it also helps the patient understand why you need to know so much about a headache. In fact, I know some GPs who hang this particular headache characteristics in their surgeries. Other relevant things in the history, which you mightn't think, is the colic in the baby, the recurrent abdominal pain, the car sickness, and of course 60% of headaches are worsened by menstruation in migraine. Hangover headaches are also a relevant, can be a migraine associated condition. The medication history is very important, and often people are just not prepared to admit what medication they're taking. I just take a couple of Panadol, but really you need to drill down into it, and sometimes it can be quite an intrusive conversation between yourself and the person who has the headache. But if they're taking paracetamol or the non-steroidals on more than 15 days per month, they really have fulfilled the criteria for medication overuse. If they're taking sulfidine on more than 10 days per month or Nurofen Plus, then they have medication overuse. As you all know, I'm sure, opiates are better avoided if at all possible in migraine. The term was, there was a previous term known as a rebound headache, and the international classification of giving it the number of days per month rather than the amount of medication a person takes on a particular day is very important. It's a huge problem internationally, with Ireland having about 4% of people in total, 4 in every 100 have medication overuse associated with headache. How does it happen? Well, the person takes a painkiller. They're afraid they'll get another painkiller, so they take another painkiller. Then their pain perception increase, so it becomes a vicious circle that they really need to take the painkillers continuously. The clinical examination, I suppose, if you're at the person who's got just a particularly bad headache, you'll look at the blood pressure, the respiratory and the cardiovascular system. You'll check their vision and check if they have neck stiffness, and obviously the temporomandibular joint. In the person who's less acute and has the chronic headache, I think the screening neurological examination is more relevant. So that was classified by Baker and Co. in the Canadian guidelines for the primary care treatment of headaches. And, you know, a general assessment of mental status can often be done just in general conversation, and it's quite accurate. The cranial nerves, the visual fields, and fundoscopy is pretty important. Assessment for limb weakness and coordination or reflex asymmetry. Even doing the plain old Romberg, the heel-toe walking. And once you're in the habit of it, it doesn't take too long, but it's often just to remember, just to think about doing it. So given that 95% of all headaches are migraine, what should we be advising the person who has the migraine to do when the headache starts? And it really does depend, but usually what you'll take to them is to take the medication, which we'll deal in the next slide. Try and advise them to have it to hand. And maybe, if at all possible, take a break from work, even go to a quiet room, maybe take an early lunch break, or have a friend to help with the children. So the medication, we divided into analgesia, non-steroidals, and triptans. So the person can take maybe paracetamol, naproxen, and sumatriptan, all at the one time for the headache. That is assuming the person isn't pregnant. And we have to remember all the time about the people who are pregnant, because migraine classically is more common in the 15 to 49-year-old women. In fact, 1 in 2 of all women will probably get a migraine at some time in their life, even if it's just one. So having given the advice to take the analgesia, it's also maybe important to say to them to take some motilium, as it does help absorption of the medications to get them into the small intestine, where they're absorbed a bit quicker. The triptans, I think it's worth considering the triptans. Unfortunately, about 30% of people don't respond to triptans at all. And lack of response to one doesn't mean they won't respond to another. Obviously, we need to advise them to take them early in the headache phase, not necessarily in the aura phase, but in the headache phase, as they're less effective if taken earlier. And if a particular triptan, if you've taken it at 2 different headaches at the correct time and in the correct way, and it doesn't work, it's most likely not going to work, and it's time to switch the person to another triptan. Pregnancy is always a concern, and what to take. And, you know, no pharmaceutical company will say any drug is 100% safe in pregnancy. So, you know, the paracetamol is fine by and large. Non-steroidals can be taken in low doses between 12 and 24 weeks. Sumatriptan is relatively safe, and as there's no data on other triptans. But there's where the alternatives, like there's a cap you can wear for migraine, there's some of the peppermint oils, some of the teas, the relaxation, and there's also a device that you can wear on the forehead, which is often used and is safe to use in pregnancy. If the person is having nausea or vomiting, you might consider nasal or subcutaneous triptans, suppositories, while avoiding morphine and opiate-based tablets as much as possible. I suppose if you are called to somebody who has migraine and it's pretty severe, they probably need a preventative. They might say to you initially, oh, I've only a headache now and again. But really, when you drill into it, you'll find many of them will have headaches on 4 to 6 days per month. So if the symptoms of migraine occur on 6 to 8 days per month is the international consensus, but really 4 days per month is quite disruptive. And the US shared this view and put people on preventatives earlier. You'll also see that then there's newer drugs for migraine, specific drugs, the CGRPs, and they will often, we expect they will be licensed if you're having symptoms on 4 days per month. If you have a poor response to acute medication, and of course, your diary is very important here to assess the response, to try and remember what you've taken, because there will be so long between having the headache and attending your doctor, it's very easy to forget. Up until recently, the prophylactic treatments for migraine were discovered serendipitously. They were also used in epilepsy, hypertension, and depression. The CGRPs have changed that, but unfortunately, they're only available at some neurology clinics. And, excuse me, you have to have tried at least 3 other preventative drugs in the maximum tolerated doses before you can be considered for the CGRP. I'd like to maybe raise here to let you know there is some excellent information on the Migraine Association of Ireland website, as you can see here, and they've also got an excellent diary, which I understand they'll be more than happy to send to you.
Thank you, Dr. Kearney. That was excellent. This video will be available for healthcare professionals on our website, www.migraine.ie. If you have any comments or questions about the video, or if you would like a certificate for CPD points, please contact us at info@migraine.ie. Thank you for joining us today. I hope you found this video informative.